Arthroscopic anterior cruciate ligament reconstruction, or ACL reconstruction, is a minimally invasive surgical procedure that I use to reconstruct a torn ACL in the knee. Using small arthroscopic incisions, I can replace the torn ACL, restore stability to the knee, and allow patients to return to full activity.
Indications for anterior cruciate ligament reconstruction include patients who've had an ACL tear, who regularly perform and wish to continue to perform high-level sporting activities that require pivoting, cutting, jumping, and landing. Patients who have recurrent instability of the knee or recurrent giving way despite an adequate rehabilitation program in activities of daily living. Patients with an anterior cruciate ligament tear and an associated but repairable meniscus or articular cartilage tear. Patients with an ACL tear and other ligament injuries to the same knee. And young patients with ACL tears who are too young to comply with proper activity restrictions. With regards to anatomy, the anterior cruciate ligament is a strong fibrous tissue that sits between the thigh bone, the femur, and the tibia, the shin bone. This helps control translation and rotation of the knee. The typical history for an anterior cruciate ligament injury involves an athlete attempting to make a planting, cutting, stopping, single leg maneuver without any outside contact, often resulting in an audible or perceived pop and subsequent disability that precludes continued participation in the competition that day. The typical mechanism of injury involves an athlete abruptly reacting to play in the game by planting their foot with the knee near full extension or nearly straight, the knee in valgus, slightly knock-kneed, while the muscles contract on their own without any outside contact, resulting in damage to the ACL. Physical examination typically reveals decreased range of motion of the knee, swelling in the knee joint, otherwise known as a joint effusion, palpation of tenderness along the joint lines, particularly the lateral joint line, and a positive Lachman test. The Lachman examination is performed with the knee in slight bending with an anterior force on the tibia relative to the femur. With this maneuver, the tibia will be felt to slide forward or translate forward relative to the femur, a distance greater than that of the other side. Additionally, on the normal side, there's usually a firm endpoint felt with this maneuver, whereas on the ACL injured side, there is not. This video demonstrates a positive Lachman maneuver with the tibia translating abnormally forward relative to the femur on this ACL injured knee. In a very relaxed or comfortable patient or a sleep patient, we can perform another maneuver called a pivot shift, which loads the knee tibia, across the knee joint, and up into the femur. That wire then is exchanged with an absorbable pin, which secures the graft on the femoral side, and I use a screw and another fixation device to secure the graft on the tibial side. Rehabilitation following arthroscopic assisted ACL reconstruction does not include a brace unless there's some form of meniscal repair. Typical showering is resumed after 14 days, and starting therapy at 2 to 3 days after surgery, I will allow a full return to sports and activities approximately between 4 to 6 months, depending on the patient's ability to progress through therapy. If you have any questions or concerns, don't hesitate to contact me, Stephen Chuddick, at 630-794-8668, or at my email account at stephenchuddickmd@gmail.com. Thank you.